Right. So moving swiftly onwards, we're a third of the way through, so nice and speedy. Laparoscopy. So laparoscopy has revolutionised surgery. So my mother's a retired GP, but when she was a house officer for a regular, appendix or hernia, they would have the patient in for a week. Or they would expect the patient to be in for a week. Whereas now they're doing keyhole appendix, keyhole everything, and they want to get patients out of the hospital that they're now almost just day case surgeries. So they normally have these 5 to 10 millimeter port sites with a larger one for the camera, which they normally put through the umbilicus, and then they inflate the peritoneum. So they inflate it using carbon dioxide. The choice of that is because it's basically cheap, easy, non-toxic, absorbed, and it's non-flammable. So, for example, if you were to use oxygen, then anytime they would use diathermy, they'd just explode the patient. If you were to use something like nitrogen, then that would be absorbed and you would have toxicity, so you'd get the bends. If you were to have something like, xenon, it would probably fulfill all of the criteria, but would be prohibitively expensive. So one of the things to highlight about that, though, is that as they're inflating the peritoneum, that has issues and has effects on pretty much every system, but particularly the cardiovascular system and neurospiratory system, which I'll come to in a second. One of the things to be careful about as well is that the CO2 is easily absorbed across membranes. So CO2 is lipid soluble, so it does cross the phospholipid membrane, and hence it gets absorbed into your bloodstream. So I had a case myself where it was slightly interesting, where the gynecologists hadn't used cuffed ports. So the sort of the standard port is a tube which goes through the abdominal wall, and normally it has a balloon inflated on the inside to prevent you from pulling it out. And they hadn't used cuffed ports, which then meant that the port displaced slightly, it pulled out slightly, which started driving the CO2 insufflation into the subcutaneous tissues. So they had massive surgical emphysema from carbon dioxide insufflation, to the point that it got up to their chest, and their neck was where we were able to feel it from a port on their abdomen. Now, from our perspective, we were actually quite puzzled by all of this because we hadn't initially identified that they were getting subcutaneous emphysema. So their CO2 rapidly rose from a normal sort of 4 or 5 end-tidal CO2 up to an end-tidal CO2 of about 10 in a matter of minutes, despite us increasing ventilation. And so we were thinking that this could be a malignant hypothermia, but actually it was just the surgeons being a bit useless and the CO2 getting absorbed into all of that subcutaneous tissue, which I thought was quite interesting. And it's something to have in the back of your mind, because if you have an unexplained CO2 rise, then we all start thinking of zebras with malignant hypothermia, but it could just be surgical emphysema. So the laparoscopy allows for the sort of quicker mobilization, which is good because they have lower pain. One of the pains that they do quite regularly have post-operatively, particularly if the surgeons haven't fully deflated the abdomen as they finish, is shoulder tip pain. So this is where the carbon dioxide in the peritoneum goes up and irritates the diaphragm, and basically ends up with quite significant pain in their shoulder tip. One of the things to be wary of is that this is obviously also can be a sign, or of myocardial infarction, particularly in women. It's a higher, more common sign in women. So it's one of those things that we think it's, if a patient is complaining of significant shoulder tip pain, then most likely it's going to be carbon dioxide irritating the diaphragm, but it could just be a heart attack. So it might be worth doing a troponin if you're at all worried. With regards to from the anaesthetic side, so you should be doing an endotracheal tube, which again I'll come to in a little bit. But in terms of pain relief, normally local infiltration by the surgeons is enough. But quite a few anaesthetists, particularly on the Conquest site, also like to do regional blocks for these instead. So, for example, doing tap blocks or rectus teeth blocks, and they report that they have better sort of post-op pain than just letting the surgeons do the local infiltration. So, with regards to the physiology of the laparoscopy, so from the cardiovascular system, effectively just expect anything. So you have a whole host of different responses. In younger people, generally speaking, you end up with your mean arterial pressure rising slightly, and your heart rate sort of staying the same on insufflation of the abdomen. Whereas in elderly people, more often, I find that you seem to get a decrease in the mean arterial pressure. So it's just one of those things to make sure to have your emergency drugs ready and just react to what's going on. It's often quite an annoying part of the surgery when they're insufflating, because the point where they're insufflating is also at the point where you as the anaesthetist are sort of monitoring your patient and looking to see whether or not there's any signs that they're too light or they need additional analgesia, and so their blood pressure goes up because they've got gas in their abdomen, but it sort of makes us worry that the patient is inadequately analgesed. So then I've definitely done it before, where you start chasing them with some morphine, and actually it's just their natural physiology. So why do all these sort of changes happen? So you have, with the increased intra-abdominal pressure, initially you have compression of the splanchnic veins, which then increases your venous return, which can then increase your mean arterial pressure and your cardiac and sort of it should initially increase your cardiac output, but it says here decrease your cardiac output. But anyways, apologies. And then at higher pressures, you can have compression of the IVC. And if you're compressing the splanchnic veins, it's just effectively like doing a straight leg raise. You suddenly get a rush of blood going back to the heart. If you compress the IVC, then you prevent blood getting back to the heart. So you're then decreasing your venous return. And similarly, because you are compressing all of these veins and sort of, capillary beds within your abdomen, you normally then also have an increased systemic vascular resistance, which can also increase your mean arterial pressure. If you remember the sort of equation of cardiac output times systemic vascular resistance equals your pressure. I think that's the right way. Yeah. In terms of what laparoscopy is most similar to, and something that you can sort of link it to in your Viva, is sort of similar to a prolonged Valsalva manoeuvre. One of the things that they love to ask about in Vivas as well is about the Valsalva manoeuvre and the different phases of the Valsalva manoeuvre. My take home for people doing the exam / in real life for laparoscopy is that you can just anything can happen with the cardiovascular system. So if you're really struggling, one of the things to bear in mind is that quite often the surgeons like to have the pressure up higher than they need to. And this goes the same for the respiratory physiology that I'll get to. If you are struggling, the physiology of the patient comes first, not their ease of which they can do a surgical operation. Just ask them to turn down the pressure, and they're normally quite obliging. In terms of the respiratory system, so if you've got this massive pneumoperitoneum, then it's going to be expanding, putting pressure on the diaphragm, bringing that diaphragm up into your thoracic cavity, and resisting against your positive pressure ventilation, which is expanding the lungs. So you have decreased compliance because the lungs are less stretchy because they're pushing up against this pneumoperitoneum, which inevitably ends up with you requiring increased driving pressure, so increased inspiratory pressure, which can also theoretically cause barotrauma. So for most patients, that's not an issue. But if, for example, you've got a COPD patient or something like that with emphysema, it's just something to bear in mind that your higher pressures may end up causing something like a pneumothorax even. Now, that increased abdominal pressure as well is going to be pushing on your stomach. So because it's going to be pushing on your stomach, there's an increased chance that you're basically going to have an increased intraluminal pressure, which may well then go above your gastroesophageal junction pressure, which will therefore mean that you start having passive regurgitation. So one of the things that they say is sort of an endotracheal tube is required. I mean, strictly speaking, it's not required. You could probably get away with doing it doing most laparoscopic procedures on, a second generation LMA. But it would be one of those things that's quite hard to justify from a medical legal perspective if a patient were to have an aspiration. So particularly at the junior level, just tube all of them. One of the other things that's sort of slightly interesting about it is because you're also displacing that diaphragm and shifting it up, you can result in an endobronchial intubation. So if your endotracheal tube is sitting just above the carina, you put it in that little bit too far, but it's just above the carina, but it's still inflating both lungs. If you then raise your diaphragm by 5 centimeters or something like that, then that can push your endotracheal tube down your right main bronchus and end up with an endobronchial, which is then also a difficult point where you can sort of realise that, because at the moment when they're doing pneumoperitoneum, you are expecting your airway pressures to go up. You're expecting your carbon dioxide to raise slightly because of the carbon dioxide that they insufflate the abdomen with. So you need to have a high index of suspicion as to whether or not your increased pressures and your increased CO2 is because of normal laparoscopic changes or because you've just done an endobronchial intubation. Those issues with the respiratory system are often worsened by head down, and for example, when you have a robotic surgeries, they often they need extreme head down, so the problems are even worse when you've got robotic surgeries. Any question about the cardiovascular respiratory aspects around laparoscopy? So a couple of other little bits about surgical anaesthetic considerations around laparoscopy. So one of the things that the gynecologists particularly like is something which is called a varus needle, which is a terrifying piece of equipment, in my opinion. It's basically just a large wide bore cannula that large wide bore needle, which they attach to their capnography. And they just their CO2 insufflation. So they just stick it into the peritoneum and hope that they don't hit anything. So they can hit the intestines and start pumping CO2 into the intestines. Quite recently, we've had a stomach perforation in because the surgeon, they claimed that we pumped up the stomach too much whilst we were doing face mask ventilation. So one of the suggestions that one of the consultants always does is they always put down an NG tube to deflate the stomach to try and avoid the risk that the varus needle punctures the stomach. In particularly skinny people, you can even reach the aorta with it. And similarly, you can also hit the bladder if they haven't put a catheter in. If they, for example, stick it in the IVC or the aorta, and then they don't recognise that, and they turn on the capnography, then you can also theoretically have a massive air embolism or CO2 embolism. So yeah, it's a terrifying piece of equipment, but they seem to still like it. With regards to laparoscopy in general, technically it can be more difficult. So the sort of old adage is people saying that, the old school surgeons can do an open appendix in about 10-15 minutes, whereas a sort of laparoscopic appendix will take an hour or more. And one of the things as well to bear in mind, however, is that because laparoscopy is so common now, most juniors, and indeed some of the more junior consultants, just aren't familiar with the open procedures anymore. So you have some situations where they're doing, say, a laparoscopic right hemicolectomy, and they're really struggling, and they're spending hours and hours and hours just struggling. And you suggest to them, or your consultant anaesthetist suggests, why didn't you open? And effectively they're just along the lines of, well, I can't do it open. I can do it laparoscopically, but I can't do it open. One of the things that the surgeons will often complain about is wanting a relaxed abdomen. So if the abdominal wall is particularly tense, then they can't move their instruments through the abdominal wall very easily. And so they need a relaxed abdomen, which can often be quite difficult if you are coming towards the end of the procedure and they're starting to complain that the patient isn't paralysed. So I think one of the things to remember is that a syringe of propofol gives you short-acting muscle relaxation without having to worry about sort of more permanent neuromuscular blockade. I mean, it's a slightly moot point nowadays because we've got rocuronium and C-Gamadex, but it's just something to bear in mind. One of the other things to bear in mind is that the surgeons don't like breathing. So I've put this in because there was a case which I heard about where there was a trainee who was left on their own to do a lap appendix, and the surgeons basically ended up calling in their consultant because effectively the patient was breathing. It was moving the diaphragm, and the ventilation, even just the ventilation from the ventilator, was moving the diaphragm too much that it was moving their camera, and therefore they were getting upset and they didn't feel like they could do the surgery. But ultimately, we need the patient breathing. So just remind the surgeons that they just have to make do sometimes. Sorry, went off in a bit of a tangent there. In terms of the anaesthetic considerations, so I've already said about you wanting to do an endotracheal tube. So don't do it on an LMA. It's just not worth the risk of aspiration. And as I said before, one of the surgeons likes to one of the anaesthetists likes to decompress the stomach before the surgeons get anywhere near the abdomen with a sharp needle, because of the risk of the surgeons penetrating things that they shouldn't. Similarly, normally it's a good idea to have at least one large bore cannula. So when I say large bore, at least a green, just in case they put the trocar into the aorta, which has happened before as well. One of the things to bear in mind is that your the surgical local infiltration of the surface of the skin won't cover your visceral pain. So for even when you have, for example, your laparoscopic right hemicolectomy, you've got these tiny little port sites, and you think, oh, that won't be too painful, but they've had this massive operation intra-abdominally. So quite often in those bigger surgeries, you might want to do a spinal or something as well, just to help cover that pain relief. And I've just put there about surgical ports and hypercarbia from my little anecdote earlier.